I am deeply grateful for the time a well-known cardiologist from the United States has given us today to speak about matters that touch all of us, matters that reach the young as well, and especially men from their 30 onwards and women after menopause. I have known these losses myself, young men, dear friends of our family who died of cardiac arrests, strokes and heart conditions at ages so early that the mind still struggles to accept it. Women too who suffered strokes and heart attacks after menopause when the protection of estrogen falls away and risk climbs, a stage long understudied and underserved by preventive care, though that fortunately is beginning to change. And this is not only what I have seen, the data says much the same. A large Northwestern study published this January, following more than 5,000 adults across 3 decades, found that a man's cardiovascular risk begins to climb around the age of 35, close to a decade earlier than a woman's, and that the usual explanations, blood pressure, cholesterol, smoking, diabetes, account for only a part of it.
Hi everybody, this is Tanvi Shah from the Millennial Kitchen. I also curate the Bombay Diaries. So I want to introduce to you Dr. Deepak Pasi from the United States of America. He is somebody that was educated here at our very own AIIMS at the All India Institute of Medical Sciences in New Delhi. He left in 1986 and got his specialties in not only interventional cardiology but also preventative cardiology, and that is something that I want to proactively address today. Dr. Pasi, I genuinely appreciate your time on such a short trip to India. I would like you to answer a few questions for me from all your knowledge and experience.
Thank you for inviting, and I appreciate it.
So, Dr. Pasi, I have heard that cardiovascular disease is primarily prevalent in our community, as in the Indians. Is this true? And if this is true, why is it so?
So coronary artery disease, atherosclerosis, strokes, heart attacks are very much more common in the Indian population. So the Indian subcontinent, which includes India, Pakistan, Bangladesh, Sri Lanka, we have compared this population outside of India actually with every ethnic group in the world. So they've been compared with Americans, British, Japanese, Chinese, Africans, and Indians as a subcontinent has the highest incidence of coronary artery disease, and it also happens at a younger age. It's more aggressive, higher mortality, and nobody truly knows exactly why, but it is a fact. Now, we don't have that much great data from India, but it is coming that even in India we see that the incidence of coronary artery disease is really skyrocketing, especially in the young population. The question comes up, why? And a lot of research has gone on, but we still are not 100% sure why Indians have such a high incidence of coronary artery disease. So if you compare the risk factors, for example, of Indians versus all the other ethnic groups in the world, you'll find that in Indians, for example, the cholesterol numbers are low compared to the other. Like on an average, you'll find in the outside world, Americans or British people, the average cholesterol is around 250. In Indians, it's less than 200. Still, the incidence is higher. Smoking incidence is also less. They also do more exercise. And the only risk factor that is slightly elevated in Indians is diabetes. They are more insulin resistant and they are more diabetic. Now, if you take all these risk factors, it still doesn't answer the question as to why Indians, the prevalence and the incidence of coronary artery disease is so high. So it basically means that at least in this population, you have to be really good in terms of prevention. You have to know the statistics so you can prevent things early on. Or even secondarily, if you're having any symptoms, for example, if somebody from the Indian subcontinent at the age of 40 comes in with chest pain, you shouldn't say, oh, it's nothing, it's just a GI problem or something. You should really seriously think about ruling out heart disease in those patients. So you have to know the statistics to be more cognizant and more careful when you are taking care of patients from the Indian population.
I was shocked to hear the statistic, and I would think that Indians in general, you find more Indians vegetarian from birth than you do from other parts of the world. Knowing the fact that we come from this culture where, there are primarily so many vegetarians, and knowing the fact that vegan and vegetarian diets are better for cardiac health, does it make you wonder it could have something to do with the diet?
That has been seen, but there is no proof of it. One would say that yes, in the Indian diet, we eat a lot of carbohydrates, we eat a lot of saturated fats and all the desserts that we eat. And that probably does play some role, at least, in the higher incidence of coronary artery disease and strokes.
I see. What I would like to know is, what are the basic tests and markers that one must do as preventative care to prevent strokes, heart problems, etc.? And from what age should this start?
Now remember, when we talk about coronary artery disease or atherosclerosis or deposits of fat, cholesterol in the artery, this starts at a very early age. We generally say probably in your 30s, you start having deposits of cholesterol in your arteries. And it is conceivable, and some people have reported that maybe in the Indian subcontinent, it might start in your 20s as opposed to 30s. So the earlier you start and think about these as to what you are eating, whether you are exercising or not, are you overweight, and checking your blood pressure, checking your cholesterol, checking your sugar, whether you are insulin resistant or not. Starting off early in life becomes extremely important in prevention of these events. Now, in terms of testing and all, again, you go to the physician, go to the doctor, get your blood pressure checked, get your sugar done, get your cholesterol checked, also helps. Now, as we get older, then there are other tests that we also do. One of them is called a calcium score, which is relevant between the ages of 45 and 65, because less than 45, it may be too early for the calcium buildup. And after the age of 65, you have age-related calcium buildup, so it's hard to interpret. So calcium score is very simple. 1 minute CAT scan of your chest, and it picks up the calcium in all the 3 arteries of the heart, and it gives you a number. 0 to 100, 100 to 400, 400 to 1000, greater than 1000. 0 to 100 is low risk, 100 to 400 is intermediate, high, greater than 1000 is very high risk of what we call 10-year heart attacks. So sort of gives you your current heart health and what future has for you.
I see.
And that's one of the tests that we commonly do, especially for prevention. Now, if somebody already has a heart attack, if somebody has had a stent, had a bypass, then calcium score is useless in those persons. So mainly for prevention and trying to know early if somebody has had buildup of fat and cholesterol in your arteries, so that they can take care of themselves better to prevent future episodes. There are other blood tests that we sometimes also use. There's something called a HSCRP, which is called high sensitivity C-reactive protein, which is an inflammatory marker. Now remember, coronary artery disease is actually a disease of inflammation. Somehow the arteries get inflamed, and it's easier for the cholesterol molecules to get into the arteries and build up. Now, what causes inflammation, we don't know. But obviously there are other things, all the risk factors that we have, high cholesterol, diet, lack of exercise, increases inflammation. So there's a marker for inflammation called HSCRP, which is called high sensitivity C-reactive protein, and it's a blood test.
Okay.
Normal values less than 1, 1 to 3, 3 to 10. Less than 1 is really good, low risk. 1 to 3, we call it average, and greater than 3 is high risk. So that means you have inflammation. So there is no particular treatment to lower that inflammatory marker. You can't give a medicine to lower the HSCRP, but if you know that your HSCRP is elevated, you can do better in terms of risk factor modification, taking care of yourself better with diet and exercise and weight and all that blood pressure, cholesterol. So the better you take care of yourself, you can improve your chances of not getting heart attacks and strokes.
I see. I also read, and I've noticed in my own near and dear ones, that the ones that suffer the most are males. So what is your comparison in these issues between the genders, males and females, reference age and mortality?
So men generally, and that's actually holds true throughout the world, that men tend to have higher incidence of coronary artery disease, heart attacks and stroke when you compare to women. Now this difference actually becomes almost equal after the menopause. And the current explanation is that the estrogens are protective for women in terms of prevention for heart attacks and strokes, mainly maybe through cholesterol, because women who have who are still premenopausal have a higher HDL called the high density lipoprotein, which is a protective for coronary artery disease. But after menopause, when those hormones go away, then the incidence of heart attacks and stroke become almost the same between men and women.
Oh, I see. So, Dr. Pasi, I was fortunate to be advised correctly, and after my own menopause, I did a CT angio. Who do you recommend do a CT angio? At what age? Reference men and women.
So CT angiogram, what is it? In a CT angiogram, what we do is we inject contrast dye in a person's vein, and the CAT scan takes a picture of the heart, and actually it takes a picture of the arteries, and actually you can see the arteries. We also call it a non-invasive angiogram.
Okay.
Where in terms of a catheterization, we have to, inject dye into the artery, go through the artery, inject dye into the arteries to take a picture. But in a CT angio, you can put the dye in the vein, and it takes a picture of the heart arteries and actually tells you if you've got clogged arteries or not. Now, there are some people who will do calcium score and CT at the same time. Some people will just do a calcium score, or some people will do a CT angio. The question comes up, who should get a CT angio? And that is actually pretty controversial. For example, I can tell you in America what we do is actually initially CT angio was not being approved by the insurance companies. And the main reason for that was if they start approving CT angio for every Tom, Dick and Harry, what will happen is they'll know they have a clogged artery. And then they're going to start saying, wait, do I need a stent or not? So you feel that the incidence of stenting the coronary arteries will skyrocket and bypasses may skyrocket. It may or may not help the person. If the person is not having any symptoms, you have a blockage, you just don't need a stent. But somehow in the human mind, you say, you know what, I have a blockage. Somebody needs to do something about it. Otherwise, I'm going to have a heart attack, which is not true. Research has shown that is not true. So that was the main problem for CT angio. So now what we do is, at least in the US population, as to who gets a CT angio. For example, somebody comes in with symptoms. They have chest pain, they have shortness of breath, and we do a stress test. We can be sure with a stress test, does the person have a problem or not? So instead of doing a catheterization, we'll do a CT angio. So if the CT angio is normal, then we say, hey, the symptoms are not coming from your heart, you don't need a catheterization. So it sort of avoids a catheterization in a lot of people, unnecessary catheterization. And if somebody has symptoms and the CT angio does show that you have a blockage, then you know that that person has a problem and do something about it. The question comes up, should you do CT angio at the age of 45 in everybody? And that's still controversial. And the main reason, like I mentioned, is knowing a blockage and you may not need it. And that's another topic, whether somebody needs stents and bypass or not.
I see. But as a woman that's crossed menopause, would you recommend women post their menopause get a CT angio within 2 to 3 years of menopause?
So talking about CT angios in a menopausal or postmenopausal women, the answer would be very similar. In some ways you can say, hey, everybody postmenopausal, probably not a bad idea to get a CTA. At least I'll know if I have a problem or not. And in those instances, a negative CTA is so reassuring that, hey,
it is.
I've done very well so far in my life. So, I don't have any blockages. I don't have any buildup. I'll need to continue my prevention and whatever I'm doing preventatively to prevent blockages from coming up. Now, the main problem comes up that if you start doing CTA on everybody, as that everybody postmenopausal should get a CTA, like I mentioned, that if you have a blockage, what do you do about it? That's the negative part about it. But yes, it is quite beneficial to know where you stand, whether you get a calcium score or CTA. CTA tends to be better because you can actually see the arteries, as opposed to in a calcium score, all you see is the calcium buildup. So CTA can be beneficial to know where you stand with your heart.
I see. I also have another question about a test called the carotid artery Doppler. I'm just a layperson, so I hope I said it right. But what then is the difference between the three, the calcium score, the carotid artery Doppler, and the CT angio, and when would you recommend them?
So when we talk about carotid ultrasound, we are really talking about what we call CIMT, which is carotid intimal thickness. And what they do is they measure the inside layer of the artery called the intima, and there are certain measurements that they do. And if the measurements are above normal, which means the intima is thickened, it almost always means that the person has already started developing atherosclerosis. So it's an early sign of development of atherosclerosis. And possibly some research has shown that the carotid intimal thickness may start earlier than any other buildup of atherosclerosis. So you would probably pick up the carotid intimal thickness abnormality before the calcium score. So remember, when we talk about the calcium score, you first have to have buildup of fat and cholesterol in the artery first. And then a few years later, calcium gets deposited. So you pick up the calcium score a little bit late, whereas in the carotid intimal thickness, you're going to pick up a little bit early in terms of thickness. So once you have the thickness is increased, that means your buildup has probably already started.
Is that thickness reversible?
So reversing coronary artery disease is another topic. Can you halt coronary artery disease, or can you halt as a general topic atherosclerosis? Now, some people have shown that you can halt or reverse, but if you look at the average, you probably cannot stop or reverse. Now, what you can do is by truly modifying the risk factors, diet, exercise, weight, cholesterol management, blood pressure management, quitting smoking. If you really do a good job in these risk factor modification, you can extremely slow down the rate of progression. Okay, so the slowing is definitely possible. Now, some people have shown. So you may have heard of this physician. His name is Dr. Dean Ornish, and he wrote a book about reversal of atherosclerosis. And he was probably the earliest physician who wrote about reversal of atherosclerosis. And since then, some other people have done it so. So basically, he has shown that somebody with totally vegetarian diet, okay, and risk factor modification may be able to reverse atherosclerosis. So can it be done? Yes. But how well can it be done and how commonly it can be done is a problem. So the general feeling is that if you really modify your risk factors properly, you can definitely slow down the rate of progression. There is no question about it. I've seen in my practice as well that people who have really taken care of themselves, they don't come to the cath lab for years. And there are people who really don't care. And there are actually some patients who will tell me, doc, just keep stenting. I am not going to change my diet. It's sad, but we have some people like that, and those people every 2-3 years, they are back in the cath lab having more stents.
My goodness. So tell me, in that case, what is your advice post-stenting in general, post-stenting, post-bypass? What must the lifestyle be? How does the lifestyle need to get modified? What's the care one must take post a stent and a bypass?
Now, the important thing to remember, and some people believe that, oh, I've got a stent, I've had a bypass, I'm cured. So it's extremely important to remember that this is not a cure. All you've done is you've temporized it. You put a stent, you've opened up the artery, the blood flow is established, but the disease, which is atherosclerosis, which is built up, is still there, right? Even with the bypass, you're bypassing an artery, but your own arteries are still there, and some other areas can get clogged up. So there also what we call secondary prevention, which is after an event has happened, becomes as important or even more important than primary prevention, which means you have to take care of yourself, regular exercises, better diet, taking care of other risk factors like blood pressure management. Cholesterol management becomes extremely important. Diabetes management becomes very important. And if you do not control these, 100% sure you're going to be back in the lab having more stents or more bypasses. So what we call secondary prevention is extremely important to take care of yourself. And not just the first year or two, it should be lifelong.
A lifestyle modification.
Absolutely,
basically.
Yes.
In your mind, what is the best diet to prevent cardiac issues?
So they did a study actually, and they compared vegan diet, vegetarian diet, and non-vegetarian diet. And multiple studies have come up that vegan diet and vegetarian diet are much better than non-vegetarian diet in terms of reducing the incidence of heart attacks and strokes. So diet becomes extremely important. The other thing is what kind of diet. Reducing your carbohydrates, reducing your saturated fats. Once upon a time, there was a belief: reduce fat. But now they say no, that's not the important part. The important part is the type of fats that you eat. So saturated fats really have to go down. Unsaturated fats, for example, nuts, really good. They even say a handful of nuts a day is really good in prevention of heart attacks and strokes. So diet becomes very important.
For the non-vegetarians that have lean forms of protein like chicken or fish, do you still recommend that's averse to heart health?
Now, fish actually is beneficial, because it has omega fatty acids, and those are helpful in prevention of heart attacks and strokes. So fish becomes very important. And so they say you should eat fish at least 2 to 3 times a week. So fish is very important. And what kind of fish? Oily fish. Cold water fish is generally preferable than any other kind of fish. In terms of meat can be controversial. For example, in America, where the way they raise the animals, giving growth hormones and steroids which get into the body, they use those to increase the bulk of the animal so they can, make more money of it. And so those can be extremely harmful. Now, quote unquote, organic meat, where they don't use it, and also extremely lean, you take the fat out. You eat that, once in a while, it's certainly not bad, But if you eat a lot of meat, that can be harmful. because meat itself, when it is digested in the body, it produces a chemical called trimethylalanine oxidase, which actually increases atherosclerosis. And that chemical is produced by the gut biome or the gut bacteria. And they have shown that the blood levels of that chemical are definitely higher in patients who are meat eaters as opposed to vegetarians. Actually, you won't find that in a vegetarian person if you check for that chemical. So it's a multitude of factors that does help with the diet in trying to prevent heart problems.
My other question would be, what do you recommend in terms of exercise and fitness for the general person, any age, and then a special recommendation for those that are above 50 and 60 years old in terms of exercise?
Exercise also becomes a very important part for prevention, both for primary prevention and for secondary prevention. Secondary prevention meaning after the event, and primary meaning before the event. The type of exercise is mostly aerobic exercise, not truly weightlifting. That is not considered a good exercise for prevention of heart problems, but aerobic exercise is very important. So they say the minimum required is 30 minutes a day. You can do 30 minutes at a time, or you can do 15 minutes in the morning, 15 minutes in the evening. Generally say do a mile, a mile in 15 minutes, maybe 2 miles a day, or 2 miles in 30 minutes, or if you want to go faster, 4 miles in 30 minutes. Now that's the minimum required. So you can do more, no question about it. You can do more exercises. It's definitely helpful. Now, the kind of exercise, walking is just as good as anything. You don't have to go to the gym or have a gym membership to do your exercises. Walking is fine, bicycle is fine, or if you have a treadmill at home, walking on the treadmill, all these are fine. Now, in the elderly population who have problems with arthritis or something, walking is great. You can just do the walk exercises. You don't have to do the bicycle or treadmill. So walking is really good exercise.
Okay,
and make sure it's aerobic. Make sure it's aerobic, yeah.
So, Doctor, aerobic in the sense like a high intensity workout, or what do you mean by aerobic?
So when you say aerobic, it basically means walking, treadmill, bicycle, rowing exercises that increases your heart rate.
Okay.
So it's very important for the heart rate to increase. And generally they say when you start a little bit on the slow side, warm up, do your exercise, get your heart rate up, and then you have a cool down phase, and then you stop. Okay. How much exercise or how much heart rate, if you're concentrating on the heart rate, we generally say, we come up with a number, what is called age predicted heart rate.
Okay.
So your maximum age predicted heart rate is 220 minus age. So that is your 100% age predicted heart rate. So ideally you say you exercise between 70 and 80% of that,
Okay.
So that's kind of the ideal exercise heart rate if you're monitoring the heart rate. Now sometimes you're on medications or something, medicines called beta blockers, which will slow the heart rate. So you may not be able to get that number, but if you're exercising enough that we just talked about, it should be good enough.
Doctor, I would like to ask you, when is stenting necessary? If one finds a clogged artery, should one go for stenting immediately? So what are the instances where you would take a call to do stenting or a bypass?
So there are so many people in this world who are getting stents and bypasses. The question comes up, are they really benefiting them or not? So there was a big study which was actually worldwide, all over the world, many centers, and it's called the COURAGE trial, COURAGE, and they compared people who had stents and bypass and people who had diet, exercise, weight management, all the risk factor modification and aggressive risk factor modification. And they compared after a few years, like 2,000 or 3,000 patients in one arm where they did stents and bypasses, and 2,000 to 3,000 patients in the other arm. And they compared after a few years, and they found that there was really no difference in mortality, no difference in the incidence of heart attacks, and not even in the difference between what we call angina, which are heart pains. So the current theory is, or current impression is, if you have a blockage, there's really no need to stent. You can actually do what we call, risk factor modification, and that will be just as good as putting stents. Now, there are certain situations where stents or bypass becomes very important. And about 2 or 3 instances. One is if you have a heart attack, for example. If you have a heart attack, definitely you need a stent or a bypass depending on the number of blockages. That's one situation. The second situation is, so there are 3 arteries in the heart. So the heart is like the size of a fist right behind the left breast. And you have the front artery, the back artery, and the right artery. The front artery is called the LAD, left anterior descending, also known as a widowmaker, because people die if you have a heart attack from the front artery. So if you have a blockage in the front artery, that too in the beginning of the artery, that person will benefit from stent or bypass. Okay, so that's the second situation where bypass or stents help. The third situation is if you have all the three arteries are clogged up and you have some damage to your heart, that also helps, especially if you're a diabetic. So if you have a diabetes, all three arteries are clogged up and there's some damage to the heart, that person will benefit from stent or bypass. So those are the three sort of specific situations where stents and bypass will help reduce your mortality, definitely, reduce future incidence of heart attacks. But in general population, somebody has a chest pain, for example, or shortness of breath, they go to a doctor and they have a stress test done. The stress test is abnormal and you do a catheterization and you find an 80% blockage, 1 or 2. Do you really need a stent? You really don't in those instances. You can always say, let's try medical therapy, let's try risk factor modification. If you fail that, then you can always come back and stent.
I see.
So that's the important, that you really don't need stents. And nobody has shown in that population that stents and bypass either reduce mortality, prolong life, or prevent heart attacks. They do not.
Now that is such amazing knowledge to lay people like us, because that really encourages one to think about good, healthy living habits.
100%. And actually some people have shown three vessel disease, a small population, like 50 people, and have three vessel disease, they do a catheterization and they have blockages, right? Three vessel disease means all the three arteries are plugged up. After 1 year of aggressive diet modification, they did another catheterization and they found, again, this was a reversal trial.
Wow.
They found the blockages had reduced. But you have to remember that if you're going to do that, medicines and diet and exercise, you have to be really religious in doing it. You cannot do a half-hearted approach.
Absolutely.
and feel that, oh, I don't need a stent, I'll be all right. It doesn't happen. You have to be really good at taking care of yourself, going to the doctor regularly to make sure that you are on the right track.
So Dr. Pasi, I truly appreciate your time today. I hope that this conversation will be helpful for many, many others to pay heed for preventative care.
So for all the Indians in the world, know that there's an old belief that the Indian heart is built with smaller arteries. On the weight of the evidence, that does not hold. When vessel size is measured against body frame, most studies find no real difference. The arteries are proportional to a smaller build, not inherently narrow. What is not in question is the pattern of the disease itself, earlier in life and more severe.